Well, we've got quite a good group developed now. We're up to 36 people. So I'm just going to launch in, and I just want to welcome everyone again to our panel on health workers in the time of COVID, working on the front lines. We've got a really exciting program for you today, but I first want to just go over some of those little options on the bottom of your screen. You'll see the chat function. That's where you can chat with other people on the call, share your reactions, share comments. That's really important. Let's keep this interactive. You also see that button down there for raising your hand if you want to ask a question. There's also Q&A. Add a question in there as we go through. Think of questions that you want to ask these presenters, because we're going to keep them brief so that you have time to ask your questions. I see some colleagues coming on from Eswatini. Great to have you on, Albertina. I'm very excited that you're on, and we've got quite a number of folks from different parts of the world. So I'm just really glad to see such a good turnout from the audience. So let me just start in and talk about why we're here today. We're here today because the world has been facing a crisis. We know that's COVID-19, but when it comes to that crisis, what's been happening to the health workers themselves has not gotten the attention that it deserves. Those health workers have gotten applause, that's appreciated, but they haven't seen the action that we need to really deliver them the support that they need to get through this crisis. We're seeing a massive toll on the health workers themselves. At least 17,000 dead from COVID-19, probably many more, but that's what Amnesty International recently reported, and the evidence that we have, that's the data that we have. But we're also seeing a human toll in terms of a mental health crisis. That's really been documented very well by the International Council of Nurses through a global survey. Tremendous global health, mental health crisis that nurses have been going through. We're seeing stress. We're seeing actually a wave of strikes all over the world by health workers who are asserting their rights and saying, now's time to pay attention to us and our needs. That's something that we're going to be addressing in today's presentations, because in order to really succeed against the virus, COVID-19, we need to support the health workers, and we need to support the broader system. When it comes to US engagement in global health, we need to take these issues into account, because if we only focus on global health security, we're not going to get where we need to go. We need to strengthen the system as well in order to really succeed. So that's why we're here today. We're going to hear some fantastic speakers. We have a great lineup of speakers with tremendous expertise, 5 dynamic women in the global health space, leaders in their fields and practitioners in their countries. So we're going to hear from them very shortly, but we're going to start out with an important message of welcome from Congressman David Price of North Carolina, who has been a champion for the frontline health workers.
Hello, I'm Congressman David Price, representing North Carolina's 4th District, and I'm happy to be here with you today to help celebrate World Health Worker Week, as we recognize and celebrate health workers all over the world. We, of course, are still going through a pandemic. We're hopefully seeing that light at the end of the tunnel. But this pandemic has underscored for us the critical importance of health workers at all levels on the front lines of protecting our communities. And it's also underscored the international nature of this work. Pandemics don't know boundaries. Pandemics have to be fought worldwide. And the health worker workforce worldwide has been on the front line. They're just innumerable stories of courage and sacrifice, and certainly has helped us define who is essential in this society and who really protects us and helps us pull together to overcome adversity. And health workers are really at the front of that line. So a heartfelt thank you to all of you for the work you do, for the values you embody, for the support you give to our country and to the worldwide community as we confront our challenges and hopefully build a better, healthier future. Thank you so much.
David, you're muted.
Thank you very much, Congressman Price. It's a real honor to have your support. I'm so glad we were able to present his video greeting. Congressman Price has really been a champion on these issues over a number of years, and he really reminds us of why we're here today. We should also thank a number of members of Congress who have really been champions for us in global health. The chairs of the Appropriations Committee, the Foreign Affairs Committee, Foreign Relations Committee in the Senate, many tremendous leaders. We wouldn't be here without them and their support, and the staff that work with them so hard day after day. The United States has played a leadership role in global health, and Congress deserves a lot of the credit for that. Now we really need to go even further and strengthen cross-cutting health systems, including the health workforce. The Frontline Health Worker Coalition has put together a specific proposal for supporting health systems investments, $100 million for USAID through the FY22 budget. And in the chat bar, we'll share a link to that proposal. We'll come back to that at the end. But first, I want to just go in and talk about the tremendous speakers that we have lined up. We're going to start with Kelly Saldana from the Office of Health Systems, USAID. Then we have Dr. Vanessa Kerry, co-founder and CEO of Sea Global Health, Madhu Deshmukh from CARE, and then also Polly Dunford, and also we've got our midwife and advocate from Nigeria lined up for you as well. So we're going to start in with Kelly Saldana. Kelly is the director of the Office of Health Systems for USAID's Bureau of Global Health. She has more than 20 years of experience in public health administration and international development, having served in a variety of roles within USAID, including Deputy Director of the Office of Infectious Disease and previously with the Bureau of Latin America. She was a Peace Corps volunteer in Nicaragua. Great to have you here, Kelly. Turning the floor over to you.
Thank you, David. Share my slides. Great. So first, I want to thank the Frontline Health Worker Coalition for hosting this event and to all the member organizations for their support. I'm really looking forward to hearing the perspectives and expertise from all of my colleagues on this panel. I also want to thank the congressional staff for taking the time to join us this morning, and as you noted, for their ongoing interest and dedication to improving the global health workforce. As you're aware, USAID has been at the forefront of supporting the health workforce. We recognize health workers are a critical component of all of our health programs and for meeting USAID's goals of preventing child and maternal deaths, controlling the HIV/AIDS epidemic, and combating infectious diseases. USAID supports human resources for health in more than 25 countries. We work across our development portfolio to help countries develop the diverse roles required for the delivery of health and social services, including doctors, nurses, pharmacists, social workers, community health workers, and beyond. During the COVID-19 pandemic, health workers have been responsible for adapting and expanding new models of service delivery to respond to the pandemic while maintaining essential health services. In addition to the professional stress, health workers have taken on high levels of personal risk to continue to deliver critical health services. Thousands of health workers have lost their lives due to COVID-19. And across the world, they are experiencing discrimination and violence driven by pandemic-related misinformation and stigma. Despite these many challenges, since March of last year, innovations and rapid adaptations have yielded benefits for both health workers and the clients they served, and introduced new ways of thinking about requirements for operationalizing and optimizing the health workforce.
Kelly, let me just, oh, there we go. Okay, I was just making sure that we could see your slides. Now we can see your slides.
Please say when you want the next slide. I've taken over from my side.
Okay, thank you. Okay, sorry. So I want to reflect on the challenges and opportunities that have come. And I think now is a great time, since 2021, as you all know, has been designated by WHO as the Year of the Health and Care Worker. USAID is working with governments to support human resources for health in alignment with country guidelines and strategies. We're building health worker skills in infection prevention and control, and the use of personal protective equipment, including supporting the reorganization of facility practices and workspaces to minimize the risk of transmission. And we're promoting health worker wellness through interventions that address health worker well-being, including coaching and psychosocial support. We have also worked with country governments to support health workforce planning to respond to COVID, but also to support reconfiguration of staffing and models of service delivery to maintain service provision. This has included leveraging the private sector workforce and stronger mobilization of community health workers to support response efforts. We're also leveraging existing service delivery platforms, such as those set up to respond to HIV/AIDS, to mobilize the health workforce. These efforts will contribute to future pandemic preparedness in the face of emergencies and also help pinpoint the health workforce distribution and training needs. So as you can see on the second slide, we've recently launched our vision for health system strengthening 2030. This vision will serve as a guide for implementing partners, other donors, and partner countries for thinking through how to address the health workforce from a systems perspective. Through our decades of work in human resources for health, we have seen and collected evidence to show that addressing specific health functions, like the health workforce, really requires a systems-based approach to address not only a health workforce in a singular issue, but that recognizing the interrelated nature of all of the issues within health systems. Our vision serves as a reminder for development practitioners that it's not just enough to provide training for health workers, or better facilities, or more reliable pay. Supporting policies, proper alignment of resources, local ownership and accountability, and suitable stakeholder engagement, such as between and with the communities and the workforce, are necessary for the overall system to be viable and sustainable. So one clear example of this, in northern Uganda, USAID supported improvements to quality of care to address the main causes of child and neonatal mortality. We worked with facilities to form quality improvement teams. Those teams were composed of healthcare providers across the continuum of care, from delivery to postnatal, well child vaccination, nutrition, outpatient sick child providers, and also included representatives from village health teams. The teams received biweekly coaching and mentorship sessions on how to identify gaps in care processes and organization of care, how to prioritize areas for improvement, and how to develop, test, and eventually implement the change ideas that had the potential to bring about these improvements. The improvement teams met regularly in peer-to-peer learning sessions to share their experiences, insights, and good practices. And we saw that between July of 2015 and when the program ended in March of 2017, correct and comprehensive assessment of vital endangered signs for sick children improved from 0% to 80%. The prescription of unnecessary antibiotics decreased by up to 57%, and the availability of essential medicines, as measured by reduced stockouts, decreased by up to 85%. So that's a clear example of how work across the health system achieves improved results. While there was an element of training for the health workforce, there is also broad stakeholder engagement of health providers across the continuum of care, including the village health leaders, and management practices were assessed. Social and behavior change was an important component, which was included through the mentorships. And the approach tackled the quality challenge from multiple angles. So not just simply by looking at workforce needs, but really thinking through facility management needs, drugs and stockouts, and as work for this type of capacity overall, built the ability for these high volume health facilities to hopefully manage new challenges and constantly assess the quality of their service delivery. Next slide. While approaching this problem through the systems lens of the entire health system, we also recognize that there is an ongoing projected shortage of health workers globally. WHO estimates it could be up to 18 million by 2030. And therefore, it's also important to look at the current and future workforce needs. And this begins with developing new health workers, but also includes supporting and optimizing the existing workforce. USAID recently developed a youth employment in health framework that highlights opportunities for countries to develop optimal partnerships for engaging and preparing youth to become the future health workforce. This framework was used in Indonesia to help develop recommendations for engaging youth in technical and vocational health programs and to improve the path to employment. USAID is also increasing employment opportunities for adolescent girls and young women in the health and social sectors through the Pepfar Dreams initiative. Through this initiative, Pepfar works to improve youth's age 10 to 29's access to economic and social opportunities, their share in economic growth, and their ability to live healthy lives and contribute to household, community, and national well-being. We know that women make up an estimated 70% of the existing health workforce globally, yet they're not well represented in leadership positions. So USAID also works to improve the number of women in leadership positions. In Jordan, research of over 3,000 respondents that explored this issue is now being used to inform national strategies and policies to strengthen career progression to top-level management positions for women in Jordan's health sector. Within the planning function of the health workforce, the COVID-19 pandemic has also highlighted the work that still needs to be done to improve human resource information systems to ensure real-time and up-to-date available health workforce data for planning and decision-making. Many countries still have inadequate data systems or outdated information, which slows their ability to respond to the changing health workforce needs. But within this, there are success stories. USAID's record of supporting the government of Indonesia's commitment to the health workforce and for optimizing information systems to ensure more strategic use of human resources for health data to help plan and manage for the health workforce proved crucial for supporting health workers during COVID-19. As the Ministry of Health in Indonesia was able to rapidly develop and deploy dashboards on the health workforce for reference and decision-making during response planning. Similarly, when the pandemic reached Senegal, the country was able to quickly establish regional COVID-19 task forces to map out the locations of private sector outlets and providers that could be mobilized for the response. That was due to existing data sharing forums that the country of Senegal had. The mobilization resulted in over 1,000 private providers and district and regional paramedical workers rapidly trained on COVID-19 identification, testing, response, infection prevention, and control. Similarly, in November of 2019, the Philippines Department of Health Academy launched an online training platform to reduce costs and increase access to training. The use of this training platform skyrocketed during the country's lockdowns. With the onset of COVID-19, the government developed a response package of 10 courses in addition to their ongoing slate of continuing professional development training. And these new courses have now been taken by thousands of health workers, ensuring the provision of care is meeting national standards. So now switching to modifying and optimizing the existing health workforce, we continue to recognize that the existing health worker shortages and COVID-19 have put a strain on the workforce and necessitated a rethinking and modifying of service delivery models to optimize the current workforce. In Lesotho, the government shifted 10% of each ministry's budget towards the national response to COVID-19. That caused a financial strain that, coupled with the COVID crisis, necessitated engaging the health workforce differently to maintain essential services, such as for HIV/AIDS. So working with USAID's Pepfar-funded partners, the country's introduced patient-centered approaches that are also proving beneficial to easing the health workforce constraints and easing workloads. These include decongesting facilities and conducting more home visits for health workers reducing risks and client risk of contracting virus from patients in health facilities, The use of e-pharmacy lockers to provide multi-month prescription and dispensing of ART, and the systematic task sharing between health professionals to respond to COVID needs and maintain essential service provision. And finally, the use of telehealth for notifications and reminders to support client retention. So that's just a quick overview, hopefully, of USAID's system strengthening approach to the health workforce and health workforce life cycle approach, hopefully highlighting the critical needs that health workers reflect for all of our development programs across USAID. So thank you again for the opportunity to share today.
Great, thanks very much, Kelly. That was a fascinating presentation. It's a very exciting vision based on equity, based on quality, based on resource optimization. And I think the example from Northern Uganda is really important, and the specific measures that you talked about and specific results, empirical results that you've seen in improving quality of care, which we know is absolutely critical. So lots to talk about there. We'll come back to you in the Q&A. And just to remind everyone, there is a Q&A bar at the bottom of your screen there. Add some questions in there. We'll be collecting those. And also you'll see that little chat function. Tell us where you're from and share any reactions. So thanks again. And now we're going to turn to a frontline health worker. Our theme with this World Health Worker Week is let's listen to the frontline health workers. That's why we've been collecting videos from frontline health workers from around the world. It's not too late if you are a health worker to add in your video. We'll share a link to that in the chat. But I want to open the floor now to Ola Adebayo, who's a young midwife and advocate from Nigeria. She really inspired us back in December when she briefed our coalition of frontline health workers. And so that's why we're eager to bring her back. She's the founder of Reprolife and the director of programs for the Neo Child Initiative, which is a social enterprise focused on improving health and well-being of women, girls, and young people. Thanks again, Ola, for being with us. Turning the floor over to you.
Okay, can you hear me?
Yes,
okay.
Indeed.
Hello, everyone. It's 4:30 here. Sorry, some minutes to 5. So my name is Ola Adebayo. I'm a midwife from Nigeria. I'm a young midwifery leader with the International Confederation of Midwives, also a frontline health worker, and I work in a primary health center. So during COVID, it was a whole lot for us as midwives working in our primary health center. Our primary health center, we focus on immunizations for babies, care for pregnant women, and do a whole lot of sexual reproductive health services in our health center. When the lockdown started, we had a whole lot of anxiety. Almost all of us were scared of what was going to happen to us. I had colleagues that stopped coming to work because their partners at home told them they didn't want them coming to work because of fear of COVID. We didn't know what to do. We didn't have enough PPEs to work. So when the lockdown started, we had to start closing our centers because we couldn't provide services to these women, even to their babies. Immunization services stopped, antenatal classes stopped, and we had to stop a whole lot of things, family planning also, until after the lockdown. Even after the lockdown, we're still scared because COVID numbers are still up there. So what are we supposed to do? So we had to start readjusting. We had long hours for our shifts. For shifts that we had 8 hours, 24 hours, we're going about a week to cover up for ourselves and to reduce exposure time to clients coming into the health center. And because of this, we were not sure. We felt very left out. We had to wait and sit back on, okay, what are the next steps to take? What are the things that we're supposed to do to protect ourselves, to protect the patients coming into the center? And from this, for me, I believe that it's important that, first of all, we need to start identifying midwives as frontline health workers. Midwives were being taken away from these centers and being reshuffled to COVID centers to cover up for the shortage. And were also lacking in our center. So we couldn't even provide the services. We couldn't take deliveries in our centers. Most of our women that come in for services or to have their births, we had to refer them to tertiary institutions because we were not sure of who was positive for COVID or not. So it was a whole lot for us mentally. It exhausted us physically, and we were so confused. We had no guidelines on how to care for pregnant women. We also had to limit people that were going to come in. I had other colleagues in other centers that were taken to COVID centers to work. And so there was a whole shortage in the other centers. And because services that are being given to women are not also identified as very important, we did not, the services that were being provided for women were not taken into recognition as very important at that time. We had a lot of women that missed their appointments for family planning. And because of that, we had a lot of women that got pregnant after the whole COVID lockdown. So it was a whole lot for us as women and also as midwives. And for me, because midwives are not at the center of decision making, there was no, we're not remembered. Nobody thought, okay, what would happen with these midwives? Are they supposed to be prioritized for PPEs or not? And a lot of things were going on in our minds during this period. And because of that, a lot of people stopped coming to work also because they were all scared. So it was a whole lot for us. Midwives are not considered as frontline workers. We are not invited to the decision-making tables. So policies are being made for us and just brought to us to implement. So a lot of times, if you see policies that are not working with midwives, it's because we were not involved at the policy-making process. Also, we have to prioritize protection of midwives also, provision of PPEs, wash equipment, provision of water, sanitation, and hygiene equipment in our centers is very, very important for us. After the lockdown, even after the lockdown, we still were not given enough PPEs. We had to start rationing PPEs. Even with our little pay, we had to start using our monies to get enough face masks to protect ourselves. So it is important that we actually start prioritizing midwives in decision making, in providing security for us to ensure that we are safe, because we always protect women. Midwives are women, most of us are women, and we also protect women. So we understand the best things to do for these women, but we are not recognized. We are not taken as important health workers. So for me, I believe that it's actually important that we actually start recognizing midwives. And if we're serious also about reducing maternal mortality, we have to invest in the capacity of midwives, not only with their skills, but also at leadership level. It's not enough to say, okay, we're inviting midwives to the table. We also have to build the capacity of midwives to actually take sound decisions at these tables. If a person does not have the capacity to be able to make sound decisions, then it does not make any sense to invite such person to the table. So it's important that as we're inviting midwives to the table, we're also building their capacities to actually make very sound decisions at this table. So it's important that we invest in the capacity of midwives, not only their skills, but their leadership skills, to understand the process of policy making, which is why one of the major things that I do as a young midwife leader is to actually create awareness on policy making processes for midwives in Nigeria. I also like to say that it's very important that as we're also helping midwives we're protecting them, we have to consider midwives in humanitarian settings. These people risk their lives every day to actually ensure that women give birth safely, women are not dying, and then they're not being protected. Then midwives will be very reluctant to actually go to those settings. And at the end of the day, we're still not making progress as we want to make. So it's important that we're actually investing in midwives. Investing in midwives means also investing in women. We're investing in women, we're reducing maternal and child mortality. And in Nigeria, for example, midwives actually also double as nurses sometimes. So it means that if you're investing in them, we're also investing in nurses also. So I would also like to just thank everyone for the investments that are being made in Nigeria, because we have made great progress in some of our health interventions. And I believe that more investments would actually take us to where we want to be in our health systems. So it's important that we're always investing in midwives, we're investing in women, and we're helping to reduce some of these disease burdens that affect women especially. Thank you.
Thank you, Ola. That was really helpful. I think you really brought home the urgency of these issues and what's happening day to day when it comes to all the challenges that you and other frontline health workers are facing. I'm really glad that you brought up the issue of who is sitting at the decision-making table. That's a real issue across the board when it comes to frontline health workers, in particular women health workers not being represented at key decision-making tables when it comes to not only the day-to-day, but also the COVID-19 response. So we're going to come back to you with some questions. So everyone in the audience, think about your questions, put some in the Q&A box there. I see we already have some really important ones that have already been put in the Q&A box, and share your impressions in the chat function as well. So now I'm going to turn the floor to Vanessa Kerry. Vanessa Kerry is the co-founder and CEO of Uscid Global Health, which is a global nonprofit that partners with governments to strengthen human resources for health in countries with shortages of doctors, nurses, and midwives. Under her tenure, Uscid has developed and trained more than 19,000 doctors, nurses, and midwives, and impacted hundreds of thousands of lives. Dr. Kerry is a critical care physician at Massachusetts General Hospital, where she has served on the front lines of the COVID-19 response. Thank you so much for joining our panel.
Thank you for having me. And I want to just really acknowledge and thank Congressman Price for helping to highlight the importance of this work, and to the Frontline Healthcare Workers Coalition for holding this, and to all those of you that are joining. And I'm incredibly grateful actually to my co-panelists, especially to Ola, who just has been clearly serving on a front line with some very difficult, challenges. And I'm just grateful to be here. It goes without saying this year has been extraordinarily challenging. In addition to the political strife and really long overdue reckoning about inequities in this country and the world, we have been pummeled by a pandemic and all the social, economic, and health crises it has brought. I can speak to this very personally. As mentioned, I am a critical care physician and have been working on the front lines at MGH in Boston. And I've been in and out of the ICUs throughout this pandemic. And I've seen the horrific toll of this virus up close. On inauguration day this year, I actually was standing in a patient's room while on service. The patient was on a ventilator and a breathing machine on multiple drips. His body was breaking down in absolutely painful to see ways. And as the inauguration played in the background, I was really overwhelmed by an immense dichotomy. There's tremendous opportunity in leadership of this country and the hope for the end of this pandemic, but also profound pain at the realization that for my patient, it was too late and that didn't really mean anything. And beyond the walls of my hospital, there have been a recorded 132 million COVID cases and 2.8 million lives lost, 17,000 of which have been healthcare workers. But the toll of death and suffering is actually worse if we count the thousands, even millions, whose already tenuous access to quality care has been lost. Amnesty International has reported that a healthcare worker is dying every 30 minutes because of this pandemic. And additionally, the pandemic has disrupted essential health services, which have resulted in significant setbacks to gains made in HIV/AIDS, for example, immunization programs, infant mortality, all from the reallocation of attention and resources and the devastating strain of this pandemic on health systems and the profound losses, attrition, and strain on the health workforce. This staggering human toll and tragedy, though, from COVID today is only a sentinel cry for the potential loss and suffering ahead if we fail to respond strategically to this moment and to draw from lessons in history and to summon the political will to deliver and even surpass our prior global commitments. This story is not new. We have seen this consistently in crisis, conflicts, and outbreaks, where there's more death and suffering in a decade after an event than actually from an event itself. In West Africa, disruption in services for immunizations actually are estimated to have caused more death from measles than from Ebola itself. So as we look forward to overcome this pandemic, we have to recognize that many of the current setbacks stem actually from long-term failure to establish equitable frameworks for health sector investment and capacity building. And this failure is most acute in the area of the health workforce investment. Understandably, we have spent years looking for panaceas and leapfrogs to get us out of this underinvestment in the health system. We've looked at artificial intelligence, telehealth, technology, and digital information flows, all of which do and can augment health services. But these technologies cannot replace dignified, patient-centered care. Appropriate care and health innovation requires health leaders with clinical knowledge, experience, and ability to synthesize real-time information. Health is a human-centered intervention. COVID has shown us this more than any other time in history, the power of and the need for the very human aspect of healthcare. Health workers are the backbone of strong health systems and the fundamental front line of delivering quality care. To give an example of our work in Seed Global Health, a nonprofit that I run, in Zambia, for example, our team has been on the front lines of not only diagnosing COVID in the absence of testing, but has been on the front lines of dealing with heart failure and non-communicable disease and maternal mortality and diabetes and infectious diseases that kill people daily. The smoldering pandemics from which people have been dying at an unfair rate for years. It just hasn't been happening all at once. And we've also been teaching. Almost every medical student and every nursing student that comes to the hospital where we work now rounds with our team to keep learning in this moment so that we can sustain the pipeline for the years to come. It is fundamentally unacceptable that in 2021, there remain such profound gaps in healthcare, both domestically and globally. The challenges and resources are not equally distributed. The countries with the highest proportion of disease also have the lowest number of healthcare workers. 80% of non-communicable disease deaths and 99% of maternal mortality are in lower and middle income countries. And yet a country like Malawi, for example, there is only one doctor for every 33,000 people. And in fact, among the 73 countries that account for 96% of global maternal deaths, only 4 have the potential midwifery workforce to deliver essential maternal, newborn, and reproductive health interventions. I know many feel the price tag of a globally coordinated multi-sector health worker investment program feels too great, and the payback period may feel too far in the future. But the case for investing is as clear as it is compelling. There are multiple examples of the painful consequences of our choice to not invest in the health workforce. A recent study actually noted that more than 8 million people die annually in low and middle income countries because of inadequate access to quality care. And that has actually resulted in 6 trillion in economic losses. 1 billion children, that is 1/7 of our world's population, is at risk of falling behind in education due to classroom closures and education disruptions. That has a generational, multi-generational, multi-year impact for us to grow, to develop, to have strong economies, to have well-being. And women have dropped out of the workforce more disproportionately than men throughout this pandemic, which also is going to have lasting socioeconomic impacts for years to come. Since 2010, the United States has actually invested over $100 billion in global health to address diseases such as HIV and tuberculosis and to support population-specific efforts like nutrition and family planning. However, our global health gains cannot rely on treating and providing life-saving medications for specific diseases. Historically, programs have focused on myriad symptoms of larger and more systemic causes. Instead, we have to leverage our investments to address what truly ails. We must prioritize investments in training health workers who are critical to delivering life-saving medications, but also to building resilient health systems so that all people have access to quality medical care. So that a child with tuberculosis in Malawi has more than a 1 in 33,000 person chance of being able to see a doctor. West Africa is an insightful example to understand the limits of business as usual. In 2014 and 2015, the global multi-sectoral response to Ebola did have success as Ebola was contained and health systems were generally rebuilt with a lens to service quality. Yet recovery was not actually able to tackle persistent, chronic, and long-term health challenges. A recent paper noted that investments in planned health worker targets for 3 of the most affected countries fall woefully short of both regional averages as well as international benchmarks, and it's going to require actually a 10-fold higher increase in the health workforce. This impact is real. The region still bears some of the worst rates of maternal mortality in the world. There is no denying that healthcare worker investments require time. They are going to cost money, and they're going to require, but they are going to require a long-term commitment. But this shouldn't deter us. It should instead challenge us and the scale of our ambitions. It should catalyze us to think critically about how we invest, on what timelines, with which partners to build country-led capacity, and how we can fund it effectively. My colleagues and I have seen the power of this approach. One healthcare provider positioned to train others has a leveraging effect across the health system and for generations. They support colleagues, they train successors, they care for patients, and they can advocate for stronger health systems. At Seed Global Health, if each of the 20,000 local providers we have trained saw only 10 patients a day, which is a decidedly low estimate when you know what these healthcare systems are seeing, that's more than 73 million patients a year receiving higher quality care, and the cost is less than $1 per patient by a long shot. Such training, though, means not only a better response to COVID today, but a lasting legacy of providers who become a network for primary care, for maternal health, and other critical services. The US has a remarkable history of helping to solve big global problems when it decides to do so, in peace, in climate, in HIV/AIDS, in development, or in health. And the health workforce is one such problem. We can reimagine and redefine what is possible and enduring through data-driven human resources for health investments that think systemically, embrace longer timelines, address gender inequity, and build a capacity. Critical investments will accelerate efforts to ensure equitable delivery of the COVID vaccine starting today. It'll reinvigorate our global promise to achieve universal healthcare and mitigate the health effects of climate change. But beyond health, these investments in the health workforce will enable socioeconomic growth, social cohesion in countries around the world, and community well-being and gender equity. As the past year has shown, the power of the health worker is immeasurable. We cannot nurture progress without the fundamental backbone of our health system, the nurses, midwives, doctors, and other healthcare providers all patients depend on for reliable, high-quality care. This doesn't need to be the challenge. It needs to be a call to action. There is no healthcare and no global health security without health workers. Today, we mourn for those lives lost, but we can honor the legacies of those lives cut short by beginning the work to rebuild and to do so immediately through the healthcare workforce. Thank you.
Thank you so much, Dr. Kerry. That is a really inspiring call to action that we all need to attend to and respond to the situation that she's highlighting. So I'm really glad you also brought up the socioeconomic impact of this and what we would see in terms of the positive impact for the global economy if we invested in the workforce, because that really is a great segue to the words of Madhu that I think we're going to hear from right now. Madhu's organization, CARE, has come out with a really important report on that topic. So Madhu Deshmukh is going to join us now. She's currently the Vice President of Program Strategy and Impact at CARE. She's been with CARE for 13 years, where she successfully built and led a global HIV/AIDS team, built an integrated family health initiative in Bihar, India, and acted as interim CEO of CARE India, and also served the leader of the Health, Equity, and Rights team. Great to have you with us, Madhu. Turning the floor over to you.
Thank you so much, David, and to the Frontline Health Worker Coalition for hosting this panel on this really important theme. It's an honor to be speaking with my fellow panelists to this audience, including the congressional staff who have joined today, demonstrating the commitment to ensuring an equitable and fast rollout of COVID-19 vaccines and response available to one and all equally. Before I begin, I specifically want to thank the bipartisan leaders on the Hill for already appropriating billions in funding to support a global response to the pandemic. Especially thank you, Congressman David Price, for highlighting and reiterating the investments and the leadership of the US to COVID-19 global pandemic, especially the commitment to frontline health workers. These investments have been critical in the past year to mitigate the impact of COVID-19 pandemic and providing a much needed response, which is a lifeline to many vulnerable communities. US's leadership on global response is also very critical and has been very critical to catalyzing commitments from wealthier nations around the world. So we are so appreciative of the leaders in Congress, especially for their effort over the past year. But as we enter into the second year of living with COVID-19, it has become more and painfully more clear that safety of any one person depends on the global community's ability to protect every person. While wealthy nations have begun inoculating their populations, we are seeing new and devastatingly lethal variants of the virus that are continuing to emerge in countries like South Africa and Brazil, and we're also seeing some of that in the US recently. So we know that if vaccinations don't effectively reach the lower income countries now, the longer term impact of COVID-19 will be catastrophic. We just heard from Ola, and we've been hearing from several frontline health workers like Ola all over the world who are putting their life at risk about the challenges that they're facing to ensure that the vulnerable communities in the lower income countries are vaccinated. I quote Karunya Devi, a social worker and a project manager from India, who told us, "The constant fear of my safety and survival became a part of me, and I continue anyway. If not me, and the many like me reaching out, there are families who will not have anyone to help them during this crisis. Nothing can stop me." So it's really women like Karunya, women like Ola, who risk their lives to protect the health of their communities. And they are the solution. They are the ones who will help us move past this pandemic, provided we ensure that they are adequately resourced, equipped, and are provided with the tools that are needed. Kerry is currently collaborating with Booz Allen Hamilton to analyze just how much of an impact global vaccine justice will have on the US economy. As we finalize the analysis, we are excited to be sharing the report soon. But our research so far is finding that if advanced economies are fully vaccinated, but the current uncoordinated approach of global vaccine delivery continues, the world risks a global GDP loss of as much as nearly 9.2 trillion in 2021 alone. And in a scenario where only half of the population in the low and middle income countries are vaccinated, the total global economic losses could be about $3.8 trillion and 671 billion in the United States, or more than 3% of United States 2019 GDP. So in such a scenario, if the United States unilaterally committed to bridging the current funding gap, it would net a domestic return on investment over 30x or 30 times. So simply stating, failing to achieve global vaccine equity, supporting the herd immunity, or nearly 75 to 80% of inoculation rates in low and middle income countries, it will devastate the global economy and US's attempts to recover economically. So what does it cost, and what is the true costing of not just acquiring, but ensuring vaccine delivery? So CARE's flagship report, Our Best Shot, women frontline health workers around the world are keeping you safe from COVID-19. This report discusses how the current global debate about vaccine equality has largely ignored a major component which is critical to successful global vaccination campaign. We have heard a lot about vaccine access, but the policymakers have ignored the importance of investments in vaccine delivery and the rollout plans. As mentioned by my fellow panelists, underinvestment in core health infrastructure, the health systems, and the workforce can seriously erode international efforts to speed COVID-19 global vaccination efforts. We know that investments are required for the low and middle income countries who are not otherwise able to meet and cover all the costs that are required to fully roll out vaccine delivery on the ground. In our Best Shot report, we found that for every $1 that a donor country invests in the vaccine acquisition, an investment of $5 in delivery is required to ensure that the vaccines actually get in the arms of the most vulnerable communities. At CARE, we have launched the Fast and Fair initiative to support equitable and fast vaccine rollout to nearly 100 million people worldwide. Using the ACT-A estimates for the cost of acquiring vaccines to inoculate about 75 to 80% of populations in nearly 88 low and middle income countries, and CARE's estimates of cost of delivering the vaccines, CARE projects that the true cost of inoculation in low and middle income countries to be at around 190 billion. This puts the US's fair share of investment in equitable vaccine delivery worldwide to be between $15 to $26 billion. We need the additional $15 to $26 billion of investment in global vaccine procurement and delivery because it is the right thing to do. And it is also economically beneficial to the US. So US faces a choice: invest between 15 to 26 billion to support the fast and fair vaccine delivery, or run the risk of continued pandemic that has already drained $6 trillion in federal stimulus and investment, and potentially could continue to damage the US economy to the tune of almost 700 billion. We need to ensure additional investments that support the key aspects of health system strengthening necessary for this equitable delivery, which is as part of US's commitment to building strong, resilient health systems, invest in protecting, paying, and acknowledging the frontline health workers, 70% of which are women, and majority of them are women of color, and many of whom, as Ola has mentioned, are underpaid or unpaid, not equipped with the PPE and measures that are necessary to protect their own health, and are left without basic workplace protections to ensure that they can do their job, which is to ensure that vaccines reach the communities and the vulnerable populations. CARE estimates that out of the $5 in delivery cost, $2.50 has to go in equipping, paying, training, empowering, and supporting the frontline health workers. So CARE really looks forward to working with the Congress on meeting the global need for fast and equitable vaccination. This means investing in vaccine delivery to ensure vaccine procurement is actually impactful, but it also means that we support and put the power in the hands of our community members on the front lines, people like Ola, our community health workers, women leaders, and hardest to reach communities. Because doing so will ensure that global investments in fighting the pandemic that US leadership has already spurred will be successful in the long term. Thank you so much for your work, for your commitment and attention. Thank you, David.
Thank you so much, Madhu. I think it's a really important report that you've come out with, and you'll notice in the chat bar that Rachel Hall from CARE has added a link to the report. Be sure you have a look at that, because the economic analysis is really striking, that if we don't take seriously the need not only to get the vaccines to the country, but actually make sure that those vaccines are injected with fair remuneration and support for the frontline health workers. We're already seeing a problem with that, actually. I'm going to put in a link in the chat to an article that we saw in Axios that talked about how already there is a risk to vaccines expiring before they're injected. Thank you again. So I'm going to turn now to our final speaker, Polly Dunford, who is the president and CEO of IntraHealth International. Polly, before joining IntraHealth, worked with USAID for almost 20 years, most recently as the global director for HIV/AIDS. Turning the floor over to you.
Thank you, David, and the Frontline Health Worker Coalition for organizing this event. And thank you to Congressman Price for your untiring support for health workers, and to the bipartisan leaders who are also supportive of this effort and have helped us come this far, and for all of the attendees today as well. And as Vanessa and Madhu said to them, our panelists. I think that my colleagues have laid out a very compelling case for investment in health workers. And so I won't repeat that. But I think it's important to note that throughout my career, I've had a focus on disease-specific investments. As David noted, I was formerly with USAID, the global director of HIV programs for USAID, and I've seen the power of investment in a disease area to achieve results. And Pepfar is a perfect case study in that. But we also know within Pepfar, the President's Malaria Initiative, also maternal neonatal child health, reproductive health, that it is with health workers that we are able to make the success. So a large part of the investments in Pepfar are actually in training, supporting, equipping health workers so that we can achieve our objectives. So even in this vertical disease funding, health workers are absolutely critical to achieving better health outcomes for communities. But also what we know is that dividing up our health investments by health area doesn't necessarily get us to a stronger system overall. We need, as our colleagues, my colleagues and fellow panelists have said before me, we need large, comprehensive investments in health systems and specifically in health workers to allow us to pivot quickly to respond to pandemics such as COVID-19. We will not get past COVID. We will not be able to roll out the vaccines. We will not have true global health security without health workers who are supported, trained, equipped, and where they need to be at the right time. We also know that as Ola was pointing out, where healthcare workers are available, there aren't enough and they aren't supported, they aren't involving in decision-making, and that is also a critical element. So a key lesson that we've learned and that Ola shared with us today is that we know that in order to be able to respond to COVID and maintain essential services at the same time, we need to invest in health workers. This case has been laid out very well today by my fellow panelists, so I will not repeat that. Congress has a major opportunity with the investments that they're making now in the COVID pandemic to ensure that these investments go to health workers as the basis for true global health security. The Frontline Health Worker Coalition, as David will mention, has a proposal to invest $100 million in health workers through USAID, not through our vertical programs, but in a horizontal way that we can invest strategically throughout countries so that we can effectively bring health workers to respond currently right now to the COVID pandemic, ensure the delivery of safe vaccines, and then also for resiliency in the future to respond to future pandemics and other diseases that arise. We need all hands on deck to support investment. So in addition to this very dedicated, intentional, horizontal investment. We need to continue to ask Pepfar, PMI, to use a portion of their investments in health workers and in health systems so that we can respond to HIV/AIDS, malaria, but also beyond these disease areas. We need the Global Fund to invest intentionally in health workers. The GFF, we need everyone, all hands on deck to invest intentionally. So we need this now to deal with COVID. We need this for the future of all critical care, and we need to prepare for future pandemics. So thank you very much.
Thank you, Polly. I think you put it really well in terms of what we really need to see the US Congress do is to make those investments across the board and for all the global health agencies to really collaborate and free up resources for cross-cutting investments. So I'm going to open the floor now to some questions. I know we already have some on tap already. There was a question that came in a little bit earlier from Mark, who says, many of us agree that we need more investment in health systems, but the challenges include defining a clear purpose when a holistic approach, while necessary, is broad, identifying the metrics that can be used to report results, impact, and outcomes, and gaining congressional support for additional funding. So what is the best way to address those challenges? One key point I think in this question is identifying the metrics that can be used to support results, impact, and outcomes. Do we have a panelist who could respond to that one in particular? I'm looking to Kelly. Can you lead off on that one?
Sure, thanks. A couple of thoughts. One, I would like to make it really clear that there's not a separation between the work that we do to strengthen health systems and the work that we do to advance global health goals. So if we want to achieve our child mortality goals, our HIV/AIDS goals, our TB goals, we need to strengthen health systems. So in some respects, it is the same goals. You can disaggregate them by equity to really look at an equity dimension that the system is doing. And then you can look at other sort of outcome level measures within the system to understand how well the system is lined up to support those goals from a underlying basis. So I do think it's critical to recognize we're not separating out the goals. In addition to that, there's lots of measures for health systems. WHO and the World Bank are putting out biannually their report to monitor SDG 3.8, which is the one on universal health coverage, which includes an indice of service coverage broadly, how well countries are covering the key essential services, and then also an indice related to financial protection, which looks at how well countries are doing to protect the population from catastrophic financial expenditures. And then in addition to that, there's things like the JEE monitoring, and USAID is working on and should launch in a month or so another sort of summary monitoring tool that can be used as a complement to those. So I think there's a whole host of metrics that we can use to measure progress, but again, always keeping an eye on the support that health systems provides for the things that we already measure in global health.
Thank you. That was really helpful. Any others on the panel that would wanted to comment on that? I think that question really kind of gets to some of the meat of it. I've got, I don't see any other questions, so I'm going to pose a question to Kelly while we've got her here, which is, you mentioned the JEE. I think that's a really important concept to bring out. That's the joint external evaluation used for countries to make sure they're ready to respond to health threats. You're suggesting that there should be some supplementary measures of success when it comes to those joint external evaluations and what those evaluations are measuring.
Yeah, so I do think that, if the pandemic has shown us anything, it's that there is not a clear separation between public health functions and health service delivery functions, especially at the district levels. I think a lot of the surveillance activity happens by community health workers who are doing some of those surveillance and notifying when they see something in the community. That's a key piece of being able to respond to the JEE. Immunization is a main package within the JEE and the ability to roll out immunization programs. So whereas I think the JEE is not fully comprehensive to everything we would want to measure in health systems, but it is certainly a measurement that exists that we can also use to track our progress. I also note health workforce is a key component in and of itself within the JEEs.
Yeah, thank you very much. I think that's a really important point to make. Just, I know we're a little bit over time here, but I don't know if anyone else in the audience has a question they would like to pose. All right, I'm going to ask just with just one more minute here to see if any of the panelists have additional comments to add based on all that you've heard. While we have our international guest on the line here too, from Nigeria, do any of our panelists have a question that they would like to pose to Ola while we have her on the line?
I think I just want to really iterate. I was very appreciative of the outline that Madhu had specifically about, we always talk about what the cost is to do something. I think we really have to think about what the cost is if we don't. And it's always hard to capture that, but that is really what we are up against in many ways, and we've already started to experience. But this is just such a critical piece of our ability to build resiliency and durability, is to have this fundamental workforce that can, move across diseases, to be able to respond to all of these things and to be on the front lines of surveillance for COVID, to deliver vaccines, but to support Ola and her colleagues who are, on the front line every day. And I think it's the cost of not doing it that we are yet to figure out how to fully quantify. We only look at it retrospectively, but that really is the urgency. We are going to lose a lot more if we don't make the upfront investment now.
Yeah, I think that's a really important point. I wanted to mention in that connection a comment that we heard from Zipporah Iregi, who's a young nurse in Kenya. She said that what nurses are finding there, the conditions are so bad in their workplace, they're not listened to, they're not given the respect that they deserve, their concerns are ignored, that young nurses are deciding to not enter the workforce. They're looking for a research project, potentially connected to Pepfar or some international donor that they can latch on to instead of entering the workforce, or they're trying to find a way to get out of the country to serve as a nurse in some other country. So we're looking at a really serious problem down the line currently, but even down the line, if we don't take these concerns seriously. So we've had a couple of really good comments in the chat. Comments here from CARE. They're going to be sharing their final analysis. So that's going to be really good. Stay tuned for that. There's an op-ed from Polly Dunford that I encourage everyone to have a look at. We also had a couple of good comments on the importance of Gender Equal Health and Care Workforce Initiative that was launched with WHO and the government of France. Thanks, Rupa, for contributing that in the chat. There's a link there, and the comment from her is, she says, we invite the U.S. government to join this initiative with a commitment for the triple gender dividend, health, gender, and economic dividend. Any comment on that initiative or reflections from Kelly? Putting you on the spot a little bit.
Sorry, was that to me?
Yeah, so what Rupa, I think, is referring to in this comment is, her organization has launched the Gender Equal Health and Care Workforce Initiative with WHO and the government of France. We invite the US government to join this initiative with a commitment for the triple gender dividend, health, gender, and economic dividend. I don't know if you're able to comment on whether the US will join the initiative, but does that sound like something the US would be favorable to?
Yeah, I mean, I think absolutely. I think the Biden-Harris administration has made it clear that equity is one of the key goals that they're working on both domestically and internationally. I think an organization like USAID that has the broader development portfolio that works not just in health, but also in education and workforce development, and and the full range of the development portfolio has a lot of assets that we could bring to an initiative like that. But I obviously can't speak on whether or not the U.S. government would intend to join something like that right now, but certainly I can see opportunities there.
Thank you very much. So I think that's a really rich discussion that we've had today. I want to thank all of our panelists. We'll look forward to circulating the recording. Thanks so much for all the participants who tuned in and provided your questions. And thanks very much to Ola for sharing your story and your concerns. We've got a whole campaign of health workers recording their videos. So those of you who are health workers, please participate in that campaign and stay tuned for all of our initiatives. Have a look at our website, Frontline Health Workers Coalition.org, where you'll find a lot of our information, including the proposal that we have made for additional spending from the US in this regard. So you'll see a number of those links in the chat. Thanks again for everyone joining today.
Thank you.